Department of Medicine Grand Rounds. I've been out of town over the past few days, and I arrived back from being out of seas last night, and it's been a little crazy already. I want to celebrate Laurel Brown. Where's Laurel? Is she here? I think she was just nominated as favorite faculty member from the medical students. So if you see Laurel, please congratulate her. Let's talk about pulmonary fibrosis. As you know, we're interested in pulmonary fibrosis. But before that, I want to give you some disclosures. Number one, I engage with my colleagues, Rob Paris, Tammy Paris, and others in clinical trials. So we have quite a bit of a relationship with industry, as industry is probably some of the few organizations that are really investing in the area of lung fibrosis these days. And of course, I'm part of the Pulmonary Fibrosis Foundation, the Hermanski Pollock Syndrome Network, which you'll find out in a minute. Now, I was in Ireland until last night, okay? This month, September, it's great that we give this lecture because this month is the Pulmonary Fibrosis Awareness Month, and September 7th was the Global Pulmonary Fibrosis Awareness Day. And I was in Ireland. How many of you have been in Ireland? I hope you have. Beautiful country, beautiful city in Dublin. And we were there for ICLAF, which is the International Colloquium on Lung and Airway Fibrosis. And the meeting was held at the beautiful Dublin Castle, which was built to protect the Norman city, but later on became the seat of the UK's government until 1922 when a treaty was developed for Irish independence. And so we were there for 3 days. It was terrific to participate in part of that history. And they took us to the Royal College of Physicians in Dublin. So where I got to see the library and got to see behind bars, this book here on disordered respiration, which I'm sure was written several hundred years ago. And I got to learn about this woman, not this one. I think you know her. This is Kathleen Florence. Kathleen Florence Lean, who was born in 1874, was very well known to the Irish people. She was very active in the suffrage movement. She was a military person involved with the Irish Citizen Army. She was incarcerated because of her efforts during the uprising. But then she became a politician and was very involved in bringing education and medical care to people, and particularly expanding the role of women in hospitals, So that was important. But I learned that there's a lot of people that we should know about in Ireland. I always start my grand rounds with some history, so I'm just going to give you a little history. You, of course, remember Robert Boyle, 1600s, who developed Boyle's Law. It says that if pressure goes, as the pressure gas tends to change as the volume changes, so it goes down as volume goes up, and it's an inverse relationship. Francis Rinn developed the first hypodermic needle, or hypodermic syringe, in 1884, which was used in people. Kathleen Lonsdale was very involved in the development of the theory and area of investigation of crystallography, and she was elected to the Royal Society of London in 1945. And Ernest Watson, who won the Nobel Prize for Physics in 1951 for artificially splitting the atom in 1932. I think that's a great accomplishment just by the way you say it. John Tyndall is somebody everybody remembers. He studied London pollution, developed the first double beam spectrophotometer, helped establish that bacteria exist. Today we think of this as common knowledge. Somebody had to come up with these ideas. And George Johnstone, who gave us the term electron when he was trying to define the particles that develop electricity. So there's tremendous medical and scientific history in Ireland that I learned, and I was very grateful. But I also did a little bit of sightseeing, and I stayed on this street where the Temple Bar is. They tell me not to stay there because people stay up until 3 a.m. in the morning singing and drinking. They were right. But this was wonderful. Get to see the people there and having fun. And it takes you away to another time when things were simpler. And we looked for a lot of great restaurants, and we found this, even in Dublin, which I felt kind of interesting. I wasn't surprised to see a Starbucks, but I was surprised to see a Papa John's. And so let me start what we're about today. This is a patient that some of you have heard me talk about before because it really begins my interest in the area of interstitial lung disease. This is a 66-year-old man who was a musician in Atlanta, during his first visit, brought to me 3 CDs so that I could listen about his work. He was the first in. He ran the show. He put in the equipment and was the last one out. By the time he came to us, he was already on oxygen. He was the last one in, first one out, and his buddies had to put all the equipment and everything to red. He could only play one set, maybe, at the most. And as you can see here, this is a 66-year-old man who was an ex-smoker, had bilateral infiltrates that you don't need a CT scan or much else to define that this is not good. But he had these characteristics. He had dry cough. He had dyspnea on exertion. He had basal crackles when you examine him. This will become important later on. He had a little bit of clubbing, and he had a physiology of restriction, and he also desaturated when he walked. In fact, he desaturated also when he was sitting. That's why he was on oxygen by that time, 24 hours a day. And his imaging studies showed infiltrates that were peripheral, basal or predominant, and there was even some honeycombing that you can see on the x-ray if you get very close. You don't need a CT scan to see honeycombing sometimes. So we're going to give you an overview of idiopathic pulmonary fibrosis. The lecture is titled Pulmonary Fibrosis, but idiopathic pulmonary fibrosis has become sort of the standard, the stereotype of when we talk about pulmonary fibrosis. But there are many kinds of entities that will give you fibrosis in lung disease. And in fact, there are many kinds of entities that look very similar in other organs. Think about glomerulosclerosis. Think about scleroderma. Think about fibrosis in the setting after an infarct in the heart. Think about the brain with several months after a stroke. All of these are fibrosing biological processes that if we were to understand one or two of them, we could potentially have implications for the treatment of several fibrosing disorders, and that's why people are now very much interested in this condition, even though 20, 30 years ago they were not. We're going to talk about the importance of multidisciplinary approaches. We're going to talk a little bit about diagnostic tools that will be helpful to you. Then we'll go into disease pathogenesis, implications for therapy, and a few novel insights. I want to start with this. This is the interstitium of the lung. These are the alveolar structures, an H&E stain, and then electron microscopy. Very thin, separate from the airways, separate from the pleura. This is the interstitium of the lung. And when we talk about interstitial lung diseases, we talk about entities that affect the interstitium of the lung. So think about that fine microstructure being obliterated or being thickened by cancer cells, by water and congestive heart failure, by fibroblasts and excessive deposition of connective tissue. Now you don't have this fine alveolar structure for gas exchange. And the first thing you detect is inability to exert yourself because your oxygen drops. And that's what interstitial lung disease is. Now, there are over 250 to 300 interstitial lung diseases. This is not just IPF. So not every ILD is IPF, and not every IPF is ILD. That's why you need a group of people who really look into this carefully. And over the past few years, there's been more of an interest in an emerging, I guess over the past 20 years, group of entities that have become the most commonly identified in the clinics of people who deal with this condition. And these are the idiopathic interstitial pneumonias. And I want to separate these from other interstitial diseases such as you see in sarcoidosis, or in hypersensitivity pneumonitis, or in eosinophilic granuloma, or in asbestosis, okay? These are idiopathic in nature, and there's only few things that actually distinguish them. And of course, the most common of these idiopathic interstitial pneumonias is idiopathic pulmonary fibrosis, which is thought to affect about 150,000 people in the United States. Now, you may think that's a lot, but think about how many COPDers are in the United States. About 20 million. Think about asthmatics, about 15 million. Think about acute lung injury, 200,000. Sarcoidosis, 50,000. Lymphangioliomyomatosis, 25,000. So this is a group of entities that falls within the orphan group category because there are less than 200,000 people in the United States based on NIH definition. Now, the idiopathic interstitial pneumonias weren't always known as such, and we didn't have this understanding of these idiopathic interstitial pneumonia. In fact, everybody who had progressive shortness of breath and fibrosis was going to be called idiopathic pulmonary fibrosis before the 1980s. They were all IPF. And yet many of these patients were known to recover. Some of them were known to respond to prednisone. Some of them were known to die independent of what you did. And so clearly we had different phenotypes that we were not understanding. So here comes the pathologist. And the pathologist comes in and says, why don't you send me all the slides of all these people you're labeling as IPF? And we're going to gather a group of pathologists with label at the head who are going to look at the patterns and see if those patterns can predict distinct clinical entities. And what they found is these patterns, okay? And this is a pattern that they saw very frequently. They had abnormalities next to or juxtaposed to normal areas, so very heterogeneous. Okay, they had fibroblastic foci, which I'll tell you a little bit about, and not much inflammation. And these were the ones that they usually saw. So because of the scientific nomenclature that they wanted to use at that day, they called it the usual interstitial pneumonitis. And this is what you call the UIP pattern. Then they saw some of them that were very nonspecific. Just a little bit of infiltration of inflammatory cells, very diffuse, very homogeneous. It's nonspecific, so why not call it nonspecific interstitial pneumonitis? And they went through that list, okay? And later on, they actually found this one, which is bronchiolitis obliterans or organized pneumonia, which is really more of an intra-airway fibrosing process, and you may see it after bone marrow transplantation. You may see it after rejection of lung transplant, and you may see it in HIV, drug-induced, viral-induced connective tissue disorders. Here's one that is always intriguing to me. This was called desquamative interstitial pneumonia because people felt that these were desquamated dead epithelial cells, and these are not. These are activated macrophages, and you will only see that in people exposed to tobacco. So these interstitial lung diseases now become what's called the idiopathic interstitial pneumonias, with this one being considered the one non-responsive to immunosuppression and the one that people felt like it was the true idiopathic pulmonary fibrosis. Now, until these days, people did not want to do biopsies and not engage much in these conditions because what are you going to do? You're going to give them prednisone anyway, and some of them may recover, some of them may not. There wasn't much. But by looking at the pathology and by defining them in distinct pathologies, people could now begin to look prospectively at how do these patients behave. So if you have IPF with UIP pathology, how do you behave? If you have IPF but you have an SIP in pathology, how do you behave? And these are studies done in the 1990s, okay, by Daniel and Brojacker, who show that if you look at distinct entities, the survival is very different. So here is UIP, what we today call idiopathic pulmonary fibrosis, which has a 50-50 chance of survival in 3 years, as opposed to nonspecific interstitial pneumonitis and others. So all of a sudden, clinicians said, whoa, there is a big difference if we categorize them by pathology. We better start doing more histological sampling on these patients. We better look at them more carefully because now we can understand that they differ in their prognosis, and patients want to know that. If they differ in their prognosis, there must be differences in the way we tackle them. So idiopathic pulmonary fibrosis, I already told you, is the one that we don't think responds well to immunosuppression and has a high mortality and has UIP, or usual interstitial pneumonitis, in the pathology. And these are people who are over 50 years of age. So if you see somebody at 35 years of age, it's very unlikely that that person has idiopathic pulmonary fibrosis unless it's a familiar case which relates to specific genetic mutations. But this is important because I just came back from Puerto Rico 2 or 3 weeks ago, and I met a young woman who was diagnosed with idiopathic pulmonary fibrosis at age 38, who underwent bronchoscopy, who underwent video-assisted thoracoscopy surgical biopsy, who was read as UIP, who was told she had only 5 years to live, and she had nothing. She had not much on CT, and the pathology was not descriptive, the way I know it, of idiopathic pulmonary fibrosis, and we should have suspected that from the beginning because of simpler age and a non-smoker, okay? So these persons have progressive dyspnea, which is usually considered over 3 months, 3 months in duration, and smoker or ex-smokers. Smokers, so over 70% of these patients have been somewhere exposed or somehow exposed to tobacco. The imaging, you have an X-ray bilateral infiltrates. You have to have usually bilateral infiltrates to have an interstitial disease, but they have a basilar process as opposed to sarcoidosis, which many of you know is more of an upper lobe process. And the HRCT pattern has what we call now a UIP pattern. So a radiologist may read on the CT consistent with a UIP pattern. I'll tell you what that is. What they're saying is, if you biopsy a person with this CT scan, you will likely find UIP on the pathology. That's what they're saying, that the characteristics of that CT are consistent with someone who you biopsy and has UIP. And when you have that, under the right conditions, you may not need histology because you already pretty much have everything you need to make a diagnosis. But if you do need histology, you're going to find fibrosis pneumonitis. You're going to find heterogeneous changes. Some areas normal, some areas not. You're going to find fibroblastic foci, which are accumulations of myofibroblasts in distinct areas. You're going to find very little inflammation. And you shouldn't find infection or anything else that would point to another diagnosis. Now, for those of you in the clinics, let me make it simple for you, okay? If you're concerned, call a pulmonologist. But I'm sure you want more than that, okay? So if you see somebody who is over 50 years of age, who has chronic shortness of breath that is slowly progressing, has some dry cough, has been a smoker or is still a smoker, and you examine them, they have bibasilar crackles, worry that this is some kind of interstitial lung disease that is likely to be an idiopathic interstitial pneumonia, and that is likely to be IPF simply on numbers. But now you have to go back and make sure that that is correct. And in fact, bibasilar crackles is sometimes the only characteristic that will point us to an interstitial lung defect. Many of these patients have no other conditions despite their age. So you might want to do pulmonary function tests. But I warn you that pulmonary function tests are not diagnostic. They give you a pattern. So if the patient has an obstructive pattern, it would suggest an obstructive disease, like COPD, like asthma. If it has a restrictive pattern, then it would suggest either congestive heart failure or chest wall abnormalities, pleural effusions, neuromuscular disorders, or true interstitial lung disease. So pulmonary function tests are helpful to evaluate impairment, to follow a patient over time, but they're not diagnostic. So what you really need is a CT scan, and I'll show you a bigger version of the CT scan, but you basically want to have this pattern of UIP, which I'll tell you in a second, and sometimes that is enough to make a diagnosis in the absence of other etiologies, in the absence of obvious exposures to asbestos, in the absence of connective tissue disorders like rheumatoid arthritis or scleroderma or polymyositis, which can give you this, in the absence of asbestos exposure, in the absence of certain drugs that can cause fibrosis. It's idiopathic. So you have to go through all that list and come out with nothing. And with this picture, that labels you IPF. And if you need pathology, then you have these findings as I mentioned here. And it's as simple as that, okay? It's as simple as that. Now, you're going to be seeing more of these patients. You will be seeing more of these patients. And because they're elderly, they're over 50 years of age, you will be seen in different clinics. You may be seeing a patient because of arthritis, or you might be seeing a patient because of chest pain, or you might be seeing a patient for another reason. If you don't pursue other questions, or you don't look at imaging studies, you might miss these patients. And this is Fernandez-Perez making an estimation based on the data available, suggesting that this is going to continue to grow over time. Our population is aging. It's not just that we're becoming more aware, it's that our population is aging, and this is a disease of aging. And I'll get back to that. So Daniel Ferret, who's now, I think, a third-year medical student, I don't know if he's here, worked with me a couple of years ago at looking at hospitalizations for IPF because we didn't understand what was happening. And even though this incidence was growing, it wasn't clear the reasons why and what were the implications in hospitalizations. And one of the things he found is that there was an increase in hospitalizations. There was an increase in length of stay. But then he started looking at cause. And in fact, if you look at IPF compared to other conditions, you start seeing that the cause increased dramatically. And there's an increase in 2005 and 2006 for unclear reasons to me, although consensus statements started to come out at that time. People were becoming more aware at that time. You'll see that in a little graph that I have in a moment about the history of IPF research. But basically, if you're hospitalized, you have an average of $80,000 for a hospitalization. And what's intriguing also is that about 20% of these now are not going home. These are patients who you discharge to another hospital or healthcare entity, chronic rehabilitation unit, a chronic ventilator unit, and so forth. So you start adding costs. And this is one of the top causes of cost, increased cost in the pulmonary world these days. So that's important. So what do you do if you have one of these patients? So I have IPF. What do? Well, this is what we do. First of all, we confirm the diagnosis. I can't tell you how many patients come to me with the wrong diagnosis. Many diagnosed with IPF who don't have it, many diagnosed with something else who have it. And so part of your job is defining, is this IPF or some other kind of interstitial lung disease? Because prognosis is different, because expenses are different, because treatment is different. And that's important. So you educate about prognosis. I already told you, 50% survival in 3 years. This is a big deal. This is not an entity that you want to just dismiss. You want to stop offenders. So if they're still smoking, or they have exposures at home, or they're a farmer and there's exposures for like diseases you called a farmer's lung and so forth. These are other entities, but they could cause problems here. You want to prevent that. Reflux has been considered an entity because aspiration of gastric contents is thought to cause chronic inflammation and ultimately repair and disrepair, causing fibrosis. So reflux is still controversial, but people are worried about this. And you deal with preventive care. No, you deal with vaccinations, and you want to deal with cough. Cough is sometimes the main problem these people want you to fix. You may be happy that you made the right diagnosis. You may be happy that you prevented them from having prednisone for 2 years. But if they go home with nothing for that cough that prevents them to go to the movies or to a restaurant because they are embarrassed of their own relentless cough, then you're missing the boat. And there's hardly any studies evaluating how do we manage cough in these patients. And it's not easy. It is very difficult. Sometimes most of the most recalcitrant symptoms these patients have. Are they a candidate for rehabilitation? We want to make sure that they are conditioned for many reasons, but in part because they may be a candidate for lung transplantation, and they have to be conditioned to do that. Do they need oxygen supplementation? The only drug this day that we know that improves survival in COPD, that improves survival in IPF, is oxygen if you need it. You can't miss that one. That's important. In treat mental issues, you think somebody sitting at home, not being able to go out and coughing and feel a short breath or is not depressed, that's going to be an issue to think about. And so many programs are now starting to put clinics with psychiatrists, psychologists, and social workers to deal with sleep disorders, for example. There's an increased incidence of this population. Of course, they're male ex-smokers and they're older, so think about that. Comorbidity, some of them have pulmonary hypertension. And today we know that if you have IPF in the presence of pulmonary hypertension, your mortality is even higher. Now, pulmonary hypertension is still a question of how you develop that. Clearly, if you destroy the parenchyma of the lung, if you destroy the alveolar septa, and those septa have vessels, you will destroy those vessels, and now you have to increase the pressure to be able to deliver the cardiac output through that lung. But there are other hypotheses that suggest that the remodeling that goes on in the interstitium is also impacting the vasculature. And so there may not be a correlation between the degree of fibrosis and the degree of pulmonary hypertension. That's something to evaluate. We used to enroll them in clinical trials. We still do because there was not much else that we could do. I'll talk to you about this. And, of course, consideration for lung transplantation. Previously, I have mentioned to you that only 2,000 to 4,000 people in the United States get access to lung transplantation. I just told you there are 150,000 IPF patients who have 50% chance of survival in 3 years. So the majority of these patients will not have access to what's considered today the definitive treatment. And my friend Alan Ramirez would say, well, it's not a treatment. You're shifting one entity for another because of all the issues related to lung transplantation. And then about a year and a half ago, but clearly last year they became available, 2 drugs came available in the market. And I want to just simplify this for you and just bring you to this image up here. And what they did is they looked at changes in pulmonary function tests, the forced vital capacity, performing a trial that waits until death being the primary outcome. And this population, where 50% of them will last more than 3 years, becomes a very difficult task for industry and NIH because of the millions of dollars invested. The first trial cost $75 million, and it was a negative trial. So we have surrogate markers, and we use forced vital capacity. There's a lot of controversy on whether this marker is the right marker to use, but at least the FDA has agreed to use this marker as an outcome parameter to define if a drug is helpful or not in the setting of pulmonary fibrosis. And what they found in this drug called pirfenidone is that in patients who were on placebo, they continued to deteriorate about a rate of 200 to 400 cc's. That's what we know. About per year, your forced vital capacity loses about 200 to 400 cc's. Notice that this is 52 weeks. But the patients of pirfenidone slowed down. Their progress, their decline in pulmonary function slowed down. So this drug does not cure you, does not reverse your disease, does not halt it. It merely slows it down. In the population that was studied with people with mild to moderate disease, not severe disease. In the same journal, this group also reported that another drug, an nintedanib, a tyrosine kinase inhibitor. Notice that I didn't tell you what pirfenidone was. We don't know how pirfenidone works. It seems to inhibit profibrotic growth factors like TGF-beta. It has many other effects, but it's not clear what is the process. And maybe that is the reason it works. It has pleiotropic effects in multiple agents. This one is a tyrosine kinase inhibitor. It inhibits the VEGF receptor, the FGF receptor, several of these tyrosine kinases, and they found the same thing. People on placebo were dropping. People on the drug were dropping at a slower rate. And these drugs now become the mainstay of the management of patients with IPF. They have certain costs, $96,000 a year, and they have certain safety problems. But in patients who are going to die from this disease, usually that's not an issue. It's never an issue that we can't handle by treating either diarrhea or skin rash or things like that. So here's what we have today. We have a disease that when it starts, you diagnose it, maybe a little bit early, maybe a little bit late. You have some comorbidities, such as depression or pulmonary hypertension or other problems. And then what you have at the end is lung transplantation, because we now have shown that prednisone, azathioprine, and acetylcysteine and other agents in multiple clinical trials in the past 15 years have shown they do not work. And in fact, we were harming patients. So when patients come to me and say, "Doc, just give me something. I have some fibrosis. You don't think it's IPF, but it's fibrosis. Give me something." I was one of those who gave people medications who did harm, who increased hospitalizations, who increased exacerbations, who increased mortality. So today, people like me are very anxious about giving patients something without understanding the true underlying pathogenesis, or at least with careful follow-up so that you can determine very quickly if it's not making a difference. So these drugs come about, and now we have a little bit of something. We have a little bit of delay in progression. And so patients and other doctors who have invested a lot of time on this may be discouraged. And I would argue this was important. This was important first because these were, in the past 15 years, were the first placebo-controlled randomized trials in IPF. The first trial in 1996, 1997 wasn't even published. So there were experts sitting around the table in the Idiopathic Pulmonary Fibrosis Clinical Research Network and the NIH arguing that you could not have an ethical placebo-controlled trial in IPF because these patients were going to die without it. And so it was difficult to get that first trial off the ground. And since then, there's been a number. So doing this was important for us. Number two, it opened opportunities for industry. This was an area where industry was not wanting to engage. Number one, few patients. Why should I develop something for 150,000 patients when I can develop something for 20 million COPDers? And I know how to do it. I just give it a little puffer, put a little bit something together. But these trials all of a sudden suggested, we can actually do something for fibrosis. And yes, there may be few of those patients, but how about the lung fibrosis for connective tissue disease? How about the lung fibrosis for asbestosis? How about if that fibrosis is similar to glomerulosclerosis or scleroderma? And all of a sudden, millions of people in the world could benefit from anti-fibrotic drugs. This came out of these trials. And of course, we learned about other ILDs. Remember that until the 1970s, we didn't understand the pathology well. These statements, as you'll see in a minute, the consensus statement describing what this entity was, didn't come in until 2000s. And so to define the criteria for inclusion and exclusion, ensure that physician had to understand what IPS was. And by understanding what IPS was, I began to understand what IPS wasn't, or what was an IPF. And we began to understand other conditions much better. Okay? And this leaves us with this. You find in the literature the statement of cirrhosis of the lung or lung cirrhosis in the early 1800s. You see descriptions of this entity in the 1960s. You see analysis of the histology that I showed you in the 1970s. You start seeing people engage in animal models and in vitro studies on fibrogenesis in the 1980s. You see the development of centers all around the United States starting in the 1990s, although the first one in Colorado was 1988-89. Then you start having clinical trials, and you have consensus statement, and IPF becomes the best studied interstitial lung disease in the world just a few years ago. And in 2015, we have access to the first 2 antifibrotic drugs, and we're expecting the cure in the next decade. That's what we're hoping. Now, let me tell you about multidisciplinary approaches, because many of our colleagues, including us, often feel that we have all the tools to make decisions on all the patients we see, and especially in academia, where we have access to stars, where people who are terrific in multiple specialties. Why not take advantage of that? Why not take advantage of that? This is not always simple or easy in Paducah or in a little town in Georgia. And this is a problem. And let me explain why. So Flaherty demonstrated that we conclude that dynamic interactions between clinicians, radiologists, and pathologists improve interserval agreement and diagnostic confidence. So he put a bunch of pathologists and described a case in an X-ray and a CT scan and said, what do you think it is? And quantified that response. Then he brought in the radiologist and said to the group, what do you think it is? And brought that response. Then brought in the pathologist. And he saw that the kappa, the intervariable difference in diagnosis started getting better. Never goes back to very high levels, but to the very good range. That means that Jesse Roman, in the absence of radiologists, and in the absence of a good pathologist, in the absence of a multidisciplinary team to take care of this, is not doing a good job. I can't. The data says so. These were all experts in that room, by the way. So that's important. The second thing is this trial, and this is a retrospective analysis of data in a single institution from Lamas, published, as you see, in 2011, before these drugs were available, where he looked at patients and examined how much time did it take you to come to a center that deals with this condition. How much time between you had the symptoms and you talked to doctors and you referred here and there and saw you and did an echo and came back, and suddenly you came to a center that said you have IPF. And he then looked at mortality. And what he found was that the longer it took, and no surprise now, the longer it took you to get there, the higher mortality. That brings to me something very important. It says we have had the capability of altering the mortality of these patients long ago. We're waiting for drugs, and yet just bringing them to a center that understands how to do this is enough to change mortality. It's not great, but it's better than no treatment at all. Think about how important that is. The other thing that is important about these centers is that not everything is IPF, as I told you. We're seeing all the other kinds of nonspecific or idiopathic interstitial pneumonias. We're seeing a lot, and perhaps the second highest group of people we're starting to see are the connective tissue-related interstitial lung disorders. Why do you think Jesse Roman's clinic is on Friday? Because rheumatology holds a clinic on Friday. And we're able to bring them back and forth, these patients, so that we make sure this is an idiopathic entity. We make sure it's not an idiopathic entity, because it could be related to some other mixed connective tissue disorder that we just haven't found. Sarcoidosis, hypersensitivity pneumonitis. This is an entity we don't think a lot about, but it's emerging as a second or third cause of interstitial lung disease that we don't understand. This is caused by something that is in the environment, and yet over 50% of the time, my patients go home without knowing what is in their environment that causes this. We know it by their presentation and by histology and perhaps other findings, but we sometimes can't find what that is. But you have to be highly suspicious. And of course, drug-induced pneumonitis and other conditions. So because of these reasons, Dr. Paris, Tammy Paris, and myself also began to develop an interest in this area in the early 2000s, and we developed the Interstitial Lung Disease program at Emory University that was part of Idiopathic Pulmonary Fibrosis Network. And we brought that team with us to University of Louisville. And as you can see here, you have our radiologist, Dr. Reed. You have our pulmonary hypertension people. Mustafa Freg, who might be in the audience, is our expert in interstitial lung diseases pathology. People who do respiratory therapy, social workers, clinical trialists, a little bit of everything. And a surgeon. You need a surgeon to do the biopsy at the right place and at the right time. That's not anybody, okay? And that's why we developed the ANCHOR program. The ANCHOR program is a program, it's called Academic and Community Groups Coming Together, where we discuss cases. We've done our 5th one just this past month, looking at different aspects where community doctors and academicians come in and present cases and discuss issues. Last time we had a couple of patients come and talk to us about how they were feeling, how they were doing, and the concerns they had. And so these are important programs so that we need a center, maybe it can't be just here. Maybe we need to develop a virtual network throughout each state that understands this condition. And that's the intent of ANCHOR, which is supported by BI. And I should mention that so that there's no concern that my conflict of interest. You need money, you use it. Okay, and this is why I went to Puerto Rico just a couple of weeks ago, and I've been going down there, and I met the wonderful and beautiful Otero sisters. Their 5th sister is missing, all of them with idiopathic pulmonary fibrosis of genetic origin, likely, but still undefined. Okay, and we're trying to get those blood samples now to kind of define that. So there's a tremendous need in Puerto Rico. As you saw some of you saw in my newsletter, there's no lung transplantation, there's no multi-center program, there's not a group of people or even a person who's excited and interested in focusing on interstitial lung disorders. And so we're now on to our 3rd center in the island of Puerto Rico, the first one in the Caribbean. And we were happy to see that the Secretary of Health in Puerto Rico named that week the Pulmonary Fibrosis Awareness Week in Puerto Rico. So we're trying to move this knowledge elsewhere because knowledge and education at this stage may do more good than just a few drugs until we find that great drug. Now, why in Puerto Rico, Dr. Roman? You could have gone to Cuba. It's now open. You could have gone to Florida. You could have gone to Bowling Green. But there's a tremendous need for understanding pulmonary fibrosis in Puerto Rico because of this entity. How many of you have heard about the Hermanski-Pollock syndrome? I see a hand way beyond the entity of the theater. So Hermanski-Pollock syndrome is a condition, it's a genetic condition. There are about 10 genes, just the last one described about a year ago. It's called HPS 1, 2, 3, 4 to 10. And they have several manifestations. First, they're albino. So many of these kids are identified when they're born. Number 2, because they're albino and they don't have enough dye in their eyes, they are legally blind. Number 3, they have platelet disorder. So they have increased bleeding. So many of the children, the boys, are identified during circumcision, or women during their first menstruation, or even during their first delivery. And so because women dye their hair and Puerto Ricans have different ancestry, they may not look albino to you. In fact, I met a lot of people that I would have swore that they were not albino. So this is difficult, and it's difficult because I told you that one of the ways to diagnose interstitial lung disorders is what? A lung biopsy. So think about doing a lung biopsy without knowing ahead of time that there's a platelet dysfunction in these patients, and several have died because of this. And there's a concern that they may not undergo transplantation. My understanding is that now 2 patients have undergone lung transplantation. And so they also can have colitis. And HPS1, which is the most common one in the island in this region, is consistently, 100% of them develop pulmonary fibrosis below age 40, and is the main cause of death in this population. 1 in 1,800 people are thought to have the mutation. You're in an island, who you're going to think you're going to connect? It's somebody, another islander. So 6 to 7 kids are thought to be born each year with this condition. This is not going away anytime soon. Okay. And this is a CT scan of a patient with Hermanski-Pollock syndrome, which doesn't look like the UIP pattern, as I'll show you in a minute. So we developed our first center in the southwest part of the island. We just announced the opening of another one, which will happen in the next few months, and the intention is to begin to propagate this understanding to the island. Now, diagnostic tools, which we use today. I told you about history of physical exam. I told you about pulmonary function tests. They're not diagnostic, but help you evaluate impairment. I told you about high-resolution CT scan, and many of you may want to do a bronchoscopy and bronchoalveolar lavage. It's great for research, but we have no idea that bronchoscopy and lavage works today, helps us today. It may help me rule out other conditions, but not rule in this entity. And histology, if I need it. And you should know that we're one of few places in the country and in the world that has access to cryobiopsy. So your patient is too ill or too old to engage in a surgical biopsy. A cryobiopsy is like a bronchoscopy, but it takes a larger piece of the tissue, has a little higher incidence of pneumothorax and bleeding, but not much compared to surgery. And sometimes we can get enough tissue to make a diagnosis, because remember, the diagnosis depends on a pattern, not on seeing a particular cell. So this is the high-resolution CT scan. Every one of these patients needs to have a high-resolution CT scan. We cannot work without HRCT. And what you'll find in IPF are basilar predominance, peripheral distribution, honeycombing, traction bronchiectasis. As the fibrosis happens, it retracts the airway so they look open, okay? And if you have all of those without having other abnormalities like lymphadenopathy or pleural effusion or nodules, if you have these and nothing else, this is characteristics of IPF, and this, with the appropriate clinical presentation, is sufficient to make a diagnosis, and a biopsy is not needed. And we think that today about only 20% of these patients are getting an open lung biopsy for diagnosis, about 20%. So we do a lot without having to take these patients to surgery. But we want to detect these patients here very early on. In fact, this patient is already ahead of the game because you can detect some areas of biopsy. By the time you see this CT scan, we're wasting time. We're wasting time. We want to detect these early. And I like to put this next series of slides to remind you how important CT is. And I often have to remind it about this. When pulmonary fellows present a case, I say, why did you order CT? It's not going to add much. But every once in a while, I am impressed. So this is a young lady who came to us with 28 years of age. This is not IPF, smoker, okay? And here's her CT. And I kept going back and forth in these x-rays. I missed this on the x-ray. And she has eosinophilic glomeruloma by histology, where you can see some inflammation and Langerhans cells surrounding the airways, okay? And how about this patient? Who dares to tell me what this patient has? Some of you have seen this before, but this is a little weird CT. This patient has interstitial disease because he has bilateral infiltrates, as you see here. The predominant, the basis. What basis? You'll see why I'm saying that. And lung crackles when they examine. I'm not kidding you. Lung crackles. Not cooperative to do PFTs, and the doctor gave him a diagnosis of idiopathic pulmonary fibrosis. This is not one of my patients. This is a terrier. Okay? All these animals and birds that you see up here can develop pulmonary fibrosis. And this is interesting because the terrier, for example, is an inbred species. No? We may need only 40 or 50 animals to come up with the right genes, as opposed to doing this in humans, there's much more admixture. And there's a company now looking at these animals to find out if they identify genes that are related to the human conditions, or at least related to the animal condition, because veterinarians are equally baffled by this condition as we are. So here's some CTs of dogs and cats, and here's the pathology of dogs and cats. Notice that this is very homogeneous, very cellular, not the UIP pattern. And in my mind, as far as I can tell, animals who are given the diagnosis of IPF, they have some kind of idiopathic interstitial pneumonia, but they don't have what we know as idiopathic pulmonary fibrosis in humans. So let's talk about disease pathogenesis. So when we talk about pathogenesis, we always think about histology. Right? And so there's your fibroblastic foci. You have an epithelium that looks a little bit abnormal. Later on, people have defined that it's dysfunctional. And you have the accumulation of myofibroblasts. And what people today think is that there's injury to the epithelium for whatever cause. It could be because of genetics plus an environmental exposure. That epithelium, if it was killed by necrosis, you would die of acute lung injury because you lose your interconnectivity of the cells, you flood with water, and now you have drowning and you die from congestive heart failure. No? But this is not what we see in IPF. What we see is this functional cell that remains, that begins to produce pro-fibrotic factors, pro-inflammatory factors, oxygen stress, attracts fibroblasts to become myofibroblasts, and now you deposit excess collagen. And the idea that this is an epithelial-driven entity is raised by the fact that some of the mutations identified are mutations related to the epithelium, like mucins, MUC5B, or S surfactant proteins. Telomerase has become very interesting for the hematologist because you may see this in myelodysplasia, and it's an aging population. It's what takes care of the length of your genes, so you don't want to shorten them too fast because you age too fast. So this is becoming quite interesting. And this is an article, if you want to know more about this, look at this article for looking at processes of mechanism of action. But basically, they're talking about how genetics they may cause constipation of the cell. So there's misfolding of certain proteins. The proteins can't fold well. So they get stuck in the endoplasmic reticulum. That is called endoplasmic reticulum stress. And that induces a whole bunch of things, from inflammatory pathways, pro-fibrotic factors, and apoptosis or death. Moises Salman presented something in 2014, where he said, this is the hypothesis we should be looking for. There's a pre-disease state where you have genetic abnormalities and abnormalities in the integrity and the function of that epithelium. You age, and now you have an epigenetic modification, so I'll tell you about that later. Then you have triggers like environmental agents, like smoking, viruses, perhaps gastric aspiration of contents, and contributing factors, stem cell exhaustion, which you'll hear about, and aberrant matrices. Now, this is very complex. How do we even model something as complex as this? So what are the implications for therapy? Well, I told you about all of this. Okay, I told you about what we do today. But then people are starting to look at specific targets. So we know that this is an epithelium, and this is the fibroblast. These are macrophages. We know that certain agents, oxidative stress reflux, can induce transforming growth factor beta, which is a pro-fibrotic factor. We know that these other factors can work through tyrosine kinase to do the same. Nintedanib works that way. We know that macrophages can induce a cytokine, interleukin-13, that actually may have the same effect. We know that TGF-beta gets activated through certain of these integrins. We know that these produce more connective tissue growth factors. LPA is a new target that has been identified that I'm not going to talk to you about. And then you produce matrices, and these lysyl oxidases sort of retract and organize these matrices very well. What's important for you to know is that all of these and more are being targeted by agents that are being tested in clinical trials today. That's when I said we're close to finding something in the next 10 to 15 years. We are close. But we don't have good models. This is the bleomycin model that is used for every drug generated, and this is a paper that showed that out of these hundreds of papers being evaluated that show that a drug worked, it didn't work in humans. We have a good model of fibrosis. We don't have a good model of IPF. So let me finish with a few slides. So I told you that this is how it works with no treatment, transplantation. This is how it works with the new drugs. We would like to have something that halts the disease. We would like to have something that reverses the disease. Perhaps we have something that prevents morbidities, maybe biomarkers to detect those patients who have early disease and even prevent this. This is the goal. Now, how about reversing condition? What you're expecting to do is to take this and put it back here. Can you do that? And so 2 years ago, we had a couple of experts come here, and I asked Andrew Tager from MIT, is this possible? He says, well, fibrosis is reversible. Ganesh Raghu says, there's no way fibrosis is reversible. Even the experts differ on whether it's reversible or not. But everybody agrees, just like Streeter wrote, that if you have honeycombing and total destruction of the roadmap, that is not reversible. And so John McDonald did that in the 1980s, where he showed that this condition looked like very scarred and fibrotic, but when he looked at the basement membrane, the original alveoli are still there. But he looked at IPF, and the alveoli is done. And his point was that's why these conditions respond to steroids and other agents, and that's why these do not. And this is John McDonald, who I trained with at Washington University. Now, so that means that honeycombing is fibrosis. So what I tell patients is, you see this area? That area I can never get back, okay? But these areas here, maybe I can. Maybe I can prevent something from happening there. And so this is another study that was important. And they used decellularized lungs. They took the lungs and decellularized them. That means they took the cells out. And then they showed that the structure of the lung was still there. And then they put normal cells back. They put some normal cells back and found that fibroblasts, for example, started to expressing more alpha-synuclein. They're becoming more myofibroblastic. They're becoming bad. So even if I give you a new cell, this is still a problem because the tissue will drive your phenotype. Okay, and that's important because cells can respond to these matrices in different ways. I'm not going to go through this now, but John taught us about fibronectin. Let me go quickly through it. If you want, fibronectin can induce monocytic cell activation. Fibronectin and collagens and other matrices can affect epithelial cells function. So cells standing on a different matrix will behave differently. Once you have abnormalities in your matrix, your phenotype of your cells are changed. And finally, Muro reported just a few years ago that if you have animals that are deficient in a specific splicing variant of this matrix molecule, they are protected against fibrosis. One of the first, if not the first demonstration of the lung, that the matrix is not just the end-stage consequence of fibrosis. It is part of the pathogenesis. Okay? So does this bring a role for stem cells? Give me a couple more minutes, please. Because people ask me all the time, I went to a doctor for $3,000, he gave me stem cells and I'm feeling better. Okay? And we were one of the first to bring that up because we reported with Mauricio Rojas while in Atlanta that if you gave animals bleomycin, they developed fibrosis. But if you co-injected them with bone marrow mesenchymal stem cells, they did not. And now we know that you don't need bone marrow stem cells. There are actual stem cells in the lung. And that has raised the question of, well, if they're there, why are they not regenerating the lung? And there's this concept of stem cell exhaustion, that in some of these patients, for some reason, these stem cells can't really repopulate and regenerate. But the point I want to make today is there is no role for stem cells in the management of these fibrotic disorders yet. Do not spend your $3,000 on this. Okay? So we want to detect this disease early. If we wait too long, we destroy the roadmap. So we want disease prevention. Okay? And you can do that perhaps by screening IPF, by evaluating their genetics. You can't do it on everybody. Maybe I'll just do it in people over age 50. You can't do it on everybody. Maybe I'll just do it in people over 50 and smokers. And you would say, well, that's still a lot of people. Well, we're doing it for COPD. Aren't we doing screens for HRCT, for nodules, for patients who are smokers within 15 years and who are over 55 years of age? We're starting to see more interstitial lung disease in those patients who are being screened for lung cancer. So there must be a way that we can start looking at this. And finally, the role of aging. And so this is two lungs. Bleomycin mouse, young, and an old mouse, the same amount of bleomycin develops excessive amount of fibrosis. So the aging lung is very susceptible to disease. This is a normal aging lung in a mouse, stained with trichrome. You can see it's a little bluer because there's more collagen there. So animals are walking around, and we probably are walking around remodeling our lung as we age. And in fact, if you look at proteases, they're increasing the old lung. If you look at all these profibrotic genes, they're all altered in the aging lung. And in fact, this one is down, and down means profibrosis. So the aging lung is a profibrotic lung. And the question to me is, how come not everybody here who is over 50 years of age is not developing fibrosis? If we could identify why not, that would be helpful. And that brings me to the concept of remodeling. That brings me to the concept that we talk about transition remodeling, where you're just changing the relative composition of the matrix, and that may be a predisposing state, so when you get true fibrosis. Don't want to get too much into that. But what is the role of smoking? Smoking does the same. This is an animal exposed to nicotine, stained for fibronectin. This is an animal exposed to nicotine, exposed to water and not nicotine. And you can see smoking is doing the same thing. You're actually remodeling your lung when you have these exposures. And you have collagen there too, by the way, just in case you think fibronectin is this thing that I don't understand. Collagen is there as well. And nicotine works through a number of receptors, and now we have reagents that can affect these receptors, and that's important. Okay, Chantix is one of these reagents. Who knows if it can work? Okay, so the question is, what brings these up? And the idea is that redox stress and inflammation can affect growth factors and induce this remodeling. And we don't know why, but epigenetic changes may be part of this. So These are some agents. I don't want to take too much of your time because I know I was late, but epigenetics has become an interesting thing. Your DNA is enrolled in a yo-yo. I used to be a yo-yo champion when I was a kid, okay? And transcription enzymes can't see it if it's all enrolled. So we have ways to unwind this. And we unwind it, we can unrepress genes or repress them by methylation or acetylation, okay? And we think that in the setting of IPF, and I won't have time for you to show that the good genes, the protected genes, are somehow downregulated, and the bad genes are somehow upregulated by epigenetics. If it's epigenetics and not genetics, I can manipulate it. And there are already agents out there that can acetylate or deacetylate or demethylate you and are in clinical trials for other conditions. That's exciting. That is exciting. So what if I told you? Suspect this disease very early on. And if you do, send them to somebody who can provide multidisciplinary management. And how do we treat? We treat with transplantation. We consider antifibrotic drugs, but there's a whole list of things we can do for these patients and help them consider engaging in clinical trials. We have gotten this far with clinical trials. We're going to be doing what we do today 20 years from now if we don't have clinical trials. Okay? So we have learned a lot about the factors and pathways involved in lung fibrogenesis. The epithelium rules, although the fibroblasts deliver, and inflammation is getting a comeback, and someday we'll talk to you about that. Aging, stem cells, genetics, the matrix will need to be better understood. We have adequate models of fibrosis, but not of IPF. We need good biomarkers of disease, and 2 drugs have emerged, but much more needs to be done. And since I came from Ireland, I'll give you this quote. Here's to a long life and a merry one. This is something you say with a beer in your hand. A quick death and an easy one, a pretty girl and an honest one, a cold beer and another one. Thank you, and my apologies for keeping you late. Those who have to leave, please go ahead. I know it's a little bit late. Anybody has any questions or comments? Yes, sir. Then we'll go back here.
What connects the cough with IPF? Because I think cough is a reflex.
Yeah. So it's interesting you call it a reflex. And when we think of reflex, we think about the nervous system. The entire lung is innervated with ramifications, particularly of the vagus, for example. And we're now testing bigotomized animals. So the idea is that as you destroy the lung and cause remodeling and inflammation in the distal parts of the lung, you are triggering input to the brain, and the lung doesn't feel pain, it feels cough. If I cut a lung in half, you don't feel it. Your pleural does, okay? But the lung does not feel pain. But cough may be a way of the brain to tell that there's something wrong. There's another question here. Yeah, he's asking whether the mechanisms that people have identified in inflammatory bowel disease are similar in IPF. There are labs all over the world studying autophagy and exophagy genes, and so they seem to be very similar. Interestingly, when you have inflammatory bowel disease, you can have some of these bronchiolitic syndromes and also interstitial disorders. So there is a big connection between the two, and we don't know why. Jeffries and Thaler back here has shown that in inflammatory bowel disease model, you have increased expression of proteases in the lung, even though the lung looks normal. So there are some connections, but we don't understand them yet. Thank you all. My apologies again for keeping you late. Yes, sir. Yes, sir. It's a wonderful talk. Thank you. I was going at the end because I started like 10 minutes.